So next presenter, Sagar, who's next?
So Dr. Amjad Ali, next.
Amjad, welcome. So please go on, load your presentation.
My slides are visual.
Yes, yes, now visible. Amjad.
So, very good morning. I'm going to present an interesting case of hairpin or reverse guide wire technique, which I used for the bifurcation stenting. So, I'm going to show two cases. So, coming to the case one, it's a 64-year-old male who underwent CVG in 2014, who presented to us around 2 years back with unstable angina. His ECG showed T-wave inversion in inferior leads with inferior lateral hypokinesia and echo with ejection fraction of 45%. He was a known case of diabetes, hypertension, and hypothyroidism, but on very compliant with his medication. So we took this patient for the coronary angiogram, which showed LED, which has some significant disease in the proximal to mid segment, and there is an antegrade flow, and there is also a competitive flow from the lima to LED, and which is a patent graft. The another artery is the LCX, which is a very dominant artery, and OM2 is a large branch which has ostial critical stenosis, but left radial to OM2 graft occluded. It's atretic basically, and the right coronary artery is a very small non-dominant artery. So we planned a case a PTC to LCX and OM2 with a bifurcation stenting, two drug-eluting stenting, we choose minicrus as a technique to for the bifurcation. So this is the angiogram showing dominant left circumflex artery and LED, some disease in the proximal segment, and this is the non-dominant right coronary artery, and lima to LED, although patent, but there's already an integrate flow from LED. And this is the graft, atretic left radial artery graft to OM. So this is the culprit artery. So we choose PTCA to LCX and OM2 with two drug-eluting agent. So this is the technique which I used to cross the obtuse marginal two branch. It's a hairpin loop method or a reverse guide wire technique. So first I crossed the LCX with a normal workhorse wire. Then I tried with different wire to cross the obtuse marginal two. But because of the angulation and significant ostial stenosis, I was not able to cross the lesion even with a workhorse wire, fielder FC, fielder XT wire, polymer jacketed wire. So what I did, I used a micro catheter. I and inserted a loop of fielder FC wire into the OM3 branch. And when I pull back the this wire from the OM3, it gradually went into the OM2 branch. So this is a technique which we called a reverse guide wire or hairpin loop technique. This is the still images which depicts the steps of this technique. We need to keep the microcatheter at the origin of the ostium, and this hairpin loop I kept into the OM3 branch, and when I pulled back slowly, gradually it entered the OM2 branch. So this is how it works. So after crossing the lesion, we gradually advance the wire into the distal part of the OM2 with the help of microcatheter. Then we pre-dilate the lesion by two different balloons in the first side branch and then the main branch. We can appreciate the angle in this balloon also, very difficult origin. So after the pre-dilatation, we took a two drug-eluting stent, and we did the bifurcation stenting with mini crush technique. After deployment pot, we did the pot, and after the pot, the recrossing of the OM2 branch is not that much difficult because of the change of the carina. We easily cross the lesion through the struts, and we did the final kissing inflation and final pot, and this is the final result. It's a good result. There is no dissection distally. Actually, there was vessel diameter was not that much great. So good TIMI3 flow with no complication, and patient was doing very good for the last 2 years, and he's completely angina free. So this is the first case which I did with the single lumen microcatheter. The another case is a 62-year-old male with post PTCA to LCX with a stable angina. We did the FFR of this proximal LED lesion, which was 0.78. So we took this patient for the PTCA to LED. So diagonal, we want to keep a wire into the diagonal, but in this case also I am not able to cross the diagonal. So what I did, we choose a dual lumen microcatheter technique for the reverse guide wire technique. In this case, we took a dual lumen microcatheter, again the fielder FC wire, and into the LED. And when we pull back the wire, it crossed the diagonal easily. So we kept this wire into the diagonal and then completed the procedure over a LED. We choose only single provisional stenting in this case. So this is the final result. Good T3 flow, although there is a ostial disease in the diagonal, but there is a T3 flow. So how to do the difficult wiring in obtuse angled vessel? These are the different methods. First, either making a large bend of the wire tip, which I tried in first case, or use of microcatheter, especially the supercross or that angled microcatheter supercross or ventures. Reverse guide wire technique, which I used in our cases, or deflection balloon technique, in which we need to inflate the balloon just distal to the ostium of the side branch, and then we can manipulate the wire to enter into the side branch. This is the diagram which I took from the Dr. Mano's YouTube channel. And actually, I learned this technique from that YouTube channel only. So we need to insert a micro polymer jacketed wire through the introducer. And then we need to make a 180-degree bend. And we need to insert this hairpin loop into the TUI. So wiring of the obtusely angled vessel is very difficult, and reverse guide wire or hairpin guide wire technique can be successful in few cases, and we need to respect all the steps of bifurcation technique. Thank you.
Thanks, Amjad. This was really good technique, and even I have used it few times in very awkward situations. I think this is very good. At times, there are different curve microcatheter available. So 90-degree, 120-degree also. So that 120-degree micro catheter can actually direct that wire into the side branch. Or I have done in few cases where the circumflex uh, ostium was very angulated. So I got that 120-degree into the left main to LED and then directed towards the circ. So that is one another I would say option. But this technique is well known and practiced by certain operators, but you have tremendously shown it, you know. So I have done slightly differently, but I don't give that 180-degree bend, which is a very, you're giving a full bend. I mean, the kink, you're kinking that wire. I have done without kinking, but a very deep curve.
Okay.
So yeah, but this is very good. I mean, both your cases were very illustrative, and it wire went very clearly and smoothly once you retracted that microcatheter back. It was really informative,
Thank
for me. Yeah. So good. I think now this is good because this will be archived. So we're going to label your archive as a this technique, as a case which will be there on the YouTube channel, right?
Thank you so much.
Thank you, Amjad. Thank you. And be here. I think we have two more cases to go.
Right.
Yeah.